Okay. Good afternoon, everybody. Welcome to this month's Value-Based Healthcast. My name is David Hanna. I'm a doctor and I work in Cardiff.
And I'm Dee Larry, and I'm Head of Value-Based Healthcare for Cwmtaf Morgannwg University Health Board.
So welcome to this month's session, which is titled, How Do You Know What Your Patients Want? For those of you who've joined us before will know, our Value-Based Healthcast is a monthly session where we bring together people from Wales and beyond who are all interested in working in the value in health and value-based healthcare space. The format of the session is about an hour long. We have two fantastic presentations today from three amazing speakers. So I'm going to hand over to Dee, and Dee can introduce our speakers.
Yep, so hi everybody. I hope your week's going well. Thank you for joining us, whether you're live or you're watching this back. I'm channeling a bit of Barbie today, so my son has said, so we're on with the pink. But it's my absolute pleasure to welcome our three speakers today. So firstly, we have Tom Kelly. He's the CEO of Sprint Limited, who have been working with our National Value in Healthcare team. We have Navjot Kaura, Assistant Director of Data and Digital for the Welsh Value in Health team, and also the Head of Value-Based Healthcare in Swansea Bay University Health Board. And we're also joined today by Chris Lambert, who is an MSK physiotherapist and lead of OA Lifestyle Services, also at Swansea Bay.
So the format of the session is that we're going to listen first of all to Tom's presentation. And after that, there'll be a couple of minutes for us to pose some questions to Tom. We've followed by Navjot and Chris's presentation. And after that point, we'll open up to the audience. So if you have questions, please type them in the chat bar. We'll do our very best to come to everybody's questions. If we don't have enough time, we do commit to getting our presenters to answer those questions offline and posting them back. So without any further delay, I'd like to introduce Tom Kelly.
Yeah, thanks very much, David. Can you hear me?
You're on mute at the moment, possibly, Tom.
No, am I? Shouldn't be. You can see. Can you hear me now? Yeah, you can. Great. Now, the first thing, sharing the screen. For some reason, it's not letting me share. Now, it's Brooke, are you able to do that for me? I'm sorry about that, but it's greyed out here.
That's okay, Tom. We'll work on that in the background.
Okay. Well,
introduce yourself and tell us what it's all about.
Yeah, great. Thanks, David. So whilst that's going on, so what I'm going to talk about is to try and respond to the question that's the topic of today's cast, and I'd like to start, and I've got a slide on this, but I'll try and describe it with a scenario. And so if you can imagine this in your minds. So a lady, an 85-year-old lady who has bowel cancer comes to the bowel cancer clinic and is told, unfortunately, that she has bowel cancer. And the clinical team tell her that because it hasn't spread, it's possible to do an operation with some pre and post-operative chemotherapy, and that they are very confident that the cancer will be cured. However, it's quite a big operation, and because of her age and other comorbidities, it's quite possible that it'll require intensive care after the operation. She might need a colostomy bag for the rest of her life, and it could take her quite some time to get back to normal. But they are confident that she'll survive, and they are confident that she will get back to her normal day-to-day activities. Now, what are you? Good, it's on the screen. What are you thinking? And obviously we can't discuss that immediately now, but I imagine what's going through some of your minds is, first of all, well, what does she want? And the answer to that is she wants to be able to spend time with her grandchildren. She wants to be pain-free, and she doesn't want at all to go into hospital and to have any form of inpatient care. Now, the clinic, which was or is a value-based healthcare clinic, capturing problems, capturing clinical outcomes, capturing patient experience, they are focused on trying to achieve the outcomes that matter to people. In this case, in inverted commas. And so the question is, are they achieving the outcomes that matter most to people? And I think what you can see is that there is a tension. The priorities that she has as a person versus the data that we're capturing sometimes in a traditional value-based healthcare sense don't always come together. And indeed, if in this scenario the team were to focus on the goals that this and preferences that this lady had, their data would look worse for it. Her survival would be worse, some of her quality of life data would be worse, and so it would look as though they were not actually delivering a high quality service. So do you mind going to the next slide? Now this story continues, because what this clinic also has embraced is value-based procurement, where they're trying to link the reimbursement of different medicines and technologies for the management of colorectal cancer with the outcomes being achieved. And of course, the better the outcomes, the higher the reimbursement. And that, you know, in principle, that seems like a good thing. And I personally think it is a good thing. And those outcomes that are being captured are the same that I was just referring to: the standardized data, the PROMs, the clinical outcomes. And of course, the goal that we have is to try and pick those medicines and technologies that are going to best contribute to improving some or all of those outcomes. But again, I think there's a question there: is that sufficient? And of course, you will know my response to that is, well, I don't think it is. What we really need to try and do, I think, is to make sure that the medicines and technologies that are available, that they are used optimally according to the priorities, the goals and preferences that that individual people have, and not simply assuming, as I think we often do, that everybody has the same goals, everybody has the same priorities. So next slide, please. So what that has led to is this idea that we've been working on over the past 4 or 5 years now, is that, well, we don't necessarily need to do anything new here, but as is often the case, we do need to try and bring things together. So value-based healthcare, which I think has had tremendous contributions to healthcare systems over the past 15 years or so, focused on standardized data, benchmarking, person-centered healthcare, which is more about individual goals and preferences and shared decision-making, and of course all of us mindful of finite resource and needing to allocate our limited resources equitably. And so this idea was, well, maybe we can try and bring these things better together, and so we just termed that person-centered value-based healthcare to emphasize this personalized element to it. Next slide. Yep, next one. Thanks. And so what that means concretely at the 3 levels of our different healthcare systems is that at the micro level, the level where healthcare professionals and people, patients interact with each other, is we think we need a far greater focus on understanding people's goals, preferences, engaging in shared decision making, and using those to shape the outcomes, the processes, the structures that we capture. Today, the estimate is in the UK, this is, which is better at this, I think, than other countries. This sort of discussion takes place in about 1 in 5, 1 in 6 typical consultations that happen across our healthcare system. So it's by no means widespread. At the meso level, so the level of the pathway, the service, the department, people, of course, need to be fully involved in the design of services. And I mean, Dee's doing some fantastic work in that in alcohol services. And I should say at the micro level, you'll hear from Chris and Navjot, of course, in a few minutes with some fantastic examples of what they're doing there. But then at the meso and macro levels, when we're thinking about allocation of resource, it seems to me, at least, that a much better understanding of our population's goals and preferences should be very helpful in informing our resource allocation decisions, so that we have a better appreciation of where we should be using those resources. And in my view, there's not really a limit to somebody's goal, but there clearly is a limit to the preferences that people can have, because we can't provide everything that everybody might want. But that's then for clinical teams to decide how they use the allocated resources to best achieve people's goals and preferences. Next slide. So, yeah, next one, and next one. Thank you very much. So why now? So I think there is an ethical dimension to this. It is absolutely right, in my view, that we are not telling people these are the outcomes that matter. We are working with people to understand what are their priorities, what are their goals, what are their preferences, and everything should follow on from that. We all face the challenge of sustainability in terms of financial sustainability, sustainability around human resource, and you know, all sorts of other things. But this is part of the solution, because we know that when we understand what people want, often they want less than what they're given. And I'll show you a tiny bit of data on that in a moment. Society is evolving rapidly, largely driven through technological innovation, and I don't think it's going to be sufficient, or it isn't sufficient now. It will become increasingly less sufficient to be able to say, you know, this is what we're doing, these are the outcomes we're working towards. That won't be tolerated. We have to work with people to understand what they want, and as I say, everything else should follow. And the only way to truly understand value is to understand what matters to people and their goals and priorities. And that's not to say that we're going to be able to do everything for everyone, of course not, but we have to understand what it is that they want. Next slide, and I'm nearly done. So just to show you just a few snippets here, so a Cochrane review at the top, 37 studies, on average, 20% of patients who participate in shared decision-making choose more conservative treatment than do patients that do not participate in shared decision-making. A Health Affairs article underneath that, just looking at hip and knee replacements, and the bit in bold at the bottom, using decision aids, 38% fewer surgery, savings of 12 to 21% over 6 months. And this one was in the US. Forth Valley in Scotland, some fantastic work just a couple of years ago now, redesigning their service using shared decision-making and personalised approaches to care, led to a massive reduction in their outpatient waiting list. And then a breast cancer study, again, back in the US, which showed that when they used shared decision-making, understanding also people's goals and preferences, a massive increase in the number of people having lumpectomies rather than mastectomies, decreasing overall costs and waiting times. So there is this is just a high level, but there is a very strong ethical, moral case for this, but also economic that we face at the moment. So finally, on to the next slide, what we're doing to try and address some of this. We've got a collaboration with a wide range of organisations internationally to try and encourage this. We think it's a very much an approach that can support waiting list management. As I say, ethically the right thing, but instead of just focusing on increasing supply of activity to address waiting lists, maybe we should also be looking at the demand profile and really making sure that people on those lists actually should be on those lists in the first place through their goal and preference understanding. Industry, the partnership development work there seems to me to be crucial to make sure that medicines and technologies truly are aligned to supporting people's goals and preferences. And then finally, on this last slide, I think part of mainstreaming this and going from the 1 in 5, 1 in 6 consultations to everything that we do is on the next slide, Brooke, is technology. I think we do need to, we're trying to develop a platform here that will record goals, that will aggregate people's goals and preferences, that will enable us to compare those. And I hope that we'll be able to embed artificial intelligence in that to be able to start tailoring these outcome data sets to people's goals and preferences so that they become personalized data sets rather than at the moment that we just use largely the same things for everyone. So sorry that I'm a little bit over there and sorry about the difficulty at the start, but I will stop there. Thanks very much.
Tom, thanks so much, and the difficulty was all ours. Thank you for your patience and adaptation. That was much appreciated. Thanks for a fantastic talk, Tom. and certainly we're going to have a chance for the members of the audience to chip in questions over the course of the session. I know I've certainly got a couple of questions off the back of that. But Dee, is there anything that was jumping out at you from Tom's presentation?
I think for me it's the humanity of the care that we deliver, and really understanding the person in front of us, not just as a hospital number or as a condition to be fixed, and how do we work with our patients to with effective communication, really, to enable them to have the health literacy that they need to be in an equal partnership, recognizing that the patient is the expert on what they hope and what their goals are to achieve, and then the clinical team have the intervention knowledge to be able to meet those goals. That's really what came back to me, is the opportunity there. But we'll come on to more questions in a bit. What about yourself?
Well, there's just when you said that, in terms of working with the patients to give them the knowledge and the skills to be able to work as an equal partner, I'm reminded of a quote which I think probably is falsely attributed to Henry Ford, but it's one that's quoted all the time, which is it. If I had asked people what they wanted, they would have said a faster horse. Now, apparently that he never said that, but nonetheless, let's not let the truth get in the way of a good quote. But I do think it's really important, because I do recognise that sometimes citizens, patients simply don't know the array of possibilities that should be open to them. All they see, or all they are presented with, is a very finite list of options. Whereas I believe that citizen patients should be actually leading and telling us what they want. Absolutely. Off the bat.
So Henry Ford did actually say you can have any colour as long as it's black. and that's almost what we're saying here, isn't it? Is when when the person comes in and says, well, actually I'd like it in bright pink, thank you very much. Yeah. But is pink available? So I think that leads us nicely into what's actually been happening on the ground with Navjot and Chris.
Okay.
Yeah.
Navjot and Chris,
over to you guys.
Take it away.
Thanks, guys. I'll start us off. Can you all see the shared PowerPoint? Thumbs up, excellent. So I'm Chris Lambert, I'm clinical lead, I'm a physio and clinical lead of the OA lifestyle program in Swansea Bay. So I'm going to share with you some of the work we've been doing in Swansea Bay around a patient-centred or person-centred approach to care, but it's specific to the MSK pathway. So most people listening on this cast will probably know the problem that I'm sharing on this slide. So lots of people on waiting lists for orthopaedic surgery. We've got over 2,000 patients in Swansea Bay waiting for knee or hip replacement currently. Most of these patients are getting worse while they're sat on these long waiting lists, and many of them are not having the support they need as well. So that's the background and the context to this talk. Now, most of this data is based on the one service, but I just wanted to show you where that service sits within the overall OA pathway in Swansea Bay. So it's the blue box or blue arrow here, and it's an early diagnosis service. The patients come in from primary care referrals with a suspected diagnosis of OA, and they get an 8-week education, exercise and diet. So it's a very much self-management, lifestyle-driven approach to managing OA, but it sits within the further options within the pathway. So patients that don't improve or want to go on to speak to a surgeon can, and then if they do get listed for surgery, replacement joint surgery, they can go on then to our prehab service. But this talk is mainly focused around that lifestyle program. So within that clinic, this is the scenario patients and clinicians alike are faced with. So which route do I go down? Surgical route, sorry, this is skipping on, or a non-surgical route, so lifestyle management. And the way we've tried to embed the patient-centered approach here is to make better decisions around these two scenarios, really. So what we've done is we're 2 years into this lifestyle program, and we collect lots of PROM data. So we've got a really good handle or understanding on what patients get from this program now. We've got over 500 patient data sets, patients that have been through this lifestyle program and completed it. And we know that it improves their walking ability to do jobs around the house, emotional well-being, ability to manage work and hobbies, and general ability to feel like their understanding of the condition and self-management skills are a lot better. So what I'm sharing with you there is those percentages are where patients have moved from being highly symptomatic in those areas with severe symptoms in those areas to being almost symptom-free in those areas. So it's a big shift there. Although it's not a huge percentage, it reflects a big change in the ability from going patient to be asymptomatic from being highly symptomatic. Areas we're not doing so well at in the lifestyle program would be affecting sleep quality. So if sleep quality is affected by pain at night, patients are generally not changing that dimension after the intervention, the lifestyle intervention. And self-care is the same and stairs is the same. So if those are symptoms that come in with at the start, there's less likelihood that the lifestyle program would affect those symptoms at the end. So how this fits into a patient-centered approach? Well, when we come to making that decision between surgical and non-surgical, what we want is to know what the patient wants to get from the treatment. What do they really want to get as a goal? And we can align that then as best as we can to the data we've got coming out from the lifestyle program and what we know from the alternative option, surgery. So examples of this patient goals we get through would be, I want to be able to strengthen my legs and walk further. I want to be able to manage my condition on my own. Surgery is not for me. I want to understand how to manage it better. So these are obviously goals that align better with a lifestyle management service, whereas a patient that comes in and simply wants to get rid of pain at night that's coming from their knee or hip that wakes them, we know that the lifestyle problems don't suggest such a great change in that dimension or that symptom. So maybe that type of patient would be better suited to go in to speak to a surgeon if that's their goal. So practically, are we collecting it? We use a digital system. We send this out to patients. We collect their prom data and we ask them what their goals are before they come into clinic. So this is available for the clinician to view before, whilst the patient's in the waiting room. We've got time then in clinic to look at this goal, discuss this goal, potentially edit the goal, making it a SMART goal for patient. And then we can monitor the goal, so we get in touch with the patient at 4 months and 12 months to see if they've achieved this goal, and there's a sliding scale of whether they've achieved it or all the way down to not achieved it and further away from my original goal than when I started off. So a typical example we'd see in clinic, 65-year-old, 5-year history knee pain, Oxford knee score 15, sort of advanced symptoms on an x-ray. Now typically you may look at that prom, you may look at the age, you may look at the radiology and think this is an example of a patient that is highly likely to go down a surgical route. But when you look at the goals, that two different sets of goals is a hypothetical patient, but if you look at two different sets of goals that patient may have, they may indicate that you go down different pathways with that patient. For example, you know, if it is a night pain issue, if it is ability to be able to manage washing and dressing, which we know the lifestyle program are not so good at changing those symptoms. We know surgery may be better at changing that pain element of their condition. So they may be a referral for surgery more indicated with those goals. With a patient that simply wants to be able to walk a bit further, improve leg strength, improve ability and self-understanding to manage their condition on their own, then a lifestyle program may be more suited to that patient. But the patient's age, none of the other dimensions would have changed there. You've simply changing the treatment management plan to suit the goals that the patient is presenting when sharing with you. So just to finish from me, what do we need to make this happen? And what I've learned over the last 6 months working in this area is that we need to collect those goals early from patients. We need to introduce it into the conversation as clinicians. We need to share the benefits of different treatments with patients and make that as outcome driven as we can. But we also need to mesh that in a little bit with more traditional decision making guidelines. For example, in MSK or OA management, that also includes the age of the patient, the BMI status of the patient, and radiology. So we need to knit in these goals with more traditional ways of decision making as well. And can we manage to do this and align these treatments to patients' expectations as best as we can? And I'll hand over to Navjot for the rest of this talk.
Thank you, Chris, and thank you, Tom. And hello, Dave and Dee. It's lovely to see you here. And I'm just going to wrap this up with a few things here. So as Tom described in his presentation, we need to think about the micro, meso, and macro level. So if we talk about the micro level, some of the interdependencies for implementation, as Tom has suggested in his presentation, are about the digital enablers, and you know, there's something about how we scale up our abilities to capture goals and prompts. So clearly, we're doing really well in NHS Wales, in particular around prompts, prompt standards. You know, the future of an all Wales prompts digital platform that marries up the standards and the prompts. So we've been doing really well in there. But actually, the question here is, how do we do that? And of course, we're doing this in Swansea Bay to a certain degree, but more can be done in terms of the solution that Tom is proposing here. The other thing is around good health literacy, as Dave, you suggested before. Not, you know, we don't have the menu out there, so we need to do better at that. And of course, a key part of this is resourcing. We can talk about all the digital tools in the world, but you know, having a digital change always causes a change on the ground, which is really important to manage around the adoption of some of those systems. Skills around data analytics and a database of outcomes specific to the patient group. So again, it requires advanced business intelligence capabilities. I'm not going to dwell a lot on that. So those are some of the capabilities required on a micro level. So if we then move on to the meso level, well, what Chris is describing at the moment is that these two services that Chris talked about, the OA lifestyle and the prehab service, sits as a part of the wider MSK pathway. So what we're saying here is, well, this approach is embedded into the wider MSK pathway, but can we do something more in terms of the other steps of the pathway and you know, incorporate those goals, you know, in a wider systems view of things here. If we then go on to the next slide, Chris. So this is a really I find this very, very helpful. Is the way Chris has been using data for the last 2 years is utilizing this data for perhaps planning the service from a patient's perspective. So as you can see, the prehab service that has been set up in Swansea Bay has been based on the data that we've been collecting from people on the waiting list to understand what's the spectrum of their disability and what sort of workforce models do we need to support those people in these areas. As you can see, the stage 2 support in terms of the MDT, the community physio, the assessments, exercise, diet, braces, etc. So the service has been planned based on that, the needs of the patients and the goals of the patients and the outcomes they're desiring from the care that we're providing to them. Now, all this is really good in terms of the ethical principles, D, that you described, and societal value, and there's no disagreement to that. But there's something about how do we evidence that the resources that we're utilizing are giving us the benefits that we need on the end-to-end pathway value from the OA lifestyle services. So in terms of the work that we've been doing with Chris in Swansea Bay, we've been quite disciplined in capturing some of the benefits from the OA lifestyle services, which is, we know that we've got 90% reduced trauma and orthopedic procedures, 60% reduced analgesic use, reduced hospital admissions, which, Tom, you suggested, you know, these are some of the benefits that we do expect out of co-production and shared decision making. In the prehab part of things, this is fairly new, so we will be quantifying some of the benefits around less wasted surgical appointments, less primary care appointments, and we have quantified some of that data as well. And where the future looks like, and I think just being very honest about it, this is a journey for all of us, right? We've started making inroads into it, but in our heads, the person-centered value-based healthcare approach will be all about focusing on aligning care to people's goals and preferences, then interpreting the data by being informed by people's priorities, and the anticipated benefits will be in terms of more efficient resource utilization than we've done previously. So this is a build on what we already are doing, and improve workforce and patient motivation by understanding patient goals better and achieving them. And this kind of aligns with the whole Welsh Value and Health Centre principles around impact, which is all about delivering value, and how do we incorporate digital health, person-centered care, education, communication and engagement, and research, industry and strategic partnerships. So it feels like quite a quite an aligned approach in terms of the topic today and the question. But the thing I want to leave the audience with is this the next slide, if you don't mind, Chris. Sorry, the next slide has disappeared. But anyways, the next slide was going to be well, we have a problem, a bigger problem in terms of if we think about the planned orthopedic care in NHS Wales, which is the macro level. So I'm just going to describe this to all of you who are listening. So in February 22, there were nearly 700,000 patients waiting for planned care. This is a 50% increase in February 2020. The modeling shows that it could take up to 7 years or more to return waiting lists to pre-pandemic levels. Now, the question here is, for all of you to think about, is, well, in your heads, how does a person-centered value-based healthcare approach, at that macro level, helps us gives us an opportunity to shape our services differently in the future based on not doing things a traditional way, but how can we shape and take this opportunity to shape our services to serve the needs of a population on a macro level in the near future. Thank you very much, and thanks for listening to us.
Well, Tom, Chris and Navjot, thank you so much for those fantastic talks. I've got heaps of questions. I don't know about Dee, but can I go first? So going back to Tom's session at the start, and I'm really interested, Tom, in this concept of clinical teams deciding how they use the resources at their disposal, because I think that's a really tricky concept. And the reason, in my experience as a clinician, as a frontline clinician, it's tricky is because often as a clinician and as a clinical team, you have just barely enough resource to do the thing that you are currently designed to do. And actually, little or no discretion over or flexibility in terms of how you use that resource. And I think often the clinical teams do know the what. Or they have the aspiration in terms of what they want to be offering to patients, but as to how they get there. And I think that system view where you have then your, I imagine from Chris and Navjot's point of view, maybe your physiotherapists and your occupational therapists and your orthopedic surgeons and your nurse specialists who may sit in slightly different teams or positions, all coordinating activity together to do something in a slightly different way, can be a really, really challenging place to get to. And so, Tom, going back to the clinical teams deciding how they use the resources at their disposal, what are the key points in organizations, Tom, or the key positions, points, influences in organizations where we need to work at and target to enable clinical teams to change what they do?
Yes, thanks, David. So in answer to that, I think this is in a way a reverse culture change, because of course this is the essence, as you're suggesting, this is the essence of why I think everybody wants to work in healthcare. You go into it because you want to improve people's lives, and what we've had is, all with good intent, is evidence-based medicine guidelines, service standards, which led to protocols, and then we've got outcomes, because we know that doesn't always lead to good outcomes following those things. But that also, there's a focus on standardizing all of that, so that also depersonalizes it. And I think what this is about trying to say is that, well, we do need those things. Of course we do, or certainly for the foreseeable future. But we now need to get back in this human element. And there are certain, I'm sure, things we can do to do that, but I think part of that is about culture, in my view, and then there's some enablement to make it happen. And I keep seeing fantastic examples of it. I mean, the myeloma, which, for those of you that don't know, blood cancer, not that common, but there's plenty of people around with it. And for myeloma, there are lots of different things you can do. You can do a stem cell transplant, it's called, where you deplete the bone marrow. You can there's CAR T cell therapy increasingly coming out. There's a range of other advanced therapeutic options that you can use, and there are lots of these options. And so I have seen great examples in Wales, actually, where the haematologists will work with the patient to say, well, what do you want? What's your, because all of these things have different side effects and different advantages and disadvantages. What are your goals? And how do we choose these therapies together that best meet what you want? And I think that's the start of this, encouraging and enabling people to do that. And then hopefully the more complicated things then around how we align the many different services that are available and best channel resources, whether it's to the physios, the occupational therapists, the medical teams, wherever it is. I hope, David, that then it sort of starts to follow. If we set the culture, if we say we want to do it, if we use these good examples, and hopefully that we make sure that the measurements that we have, that we do what Navjot was describing, that we start to capture these goals and understand the extent to which we're achieving them. That should, yeah, it's a long answer, but hopefully it gives some ideas.
Thanks, Tom. And I might actually, I might toss this one to Dee as well, as someone who's, you know, head of value-based healthcare in CONTAF. And Dee, what are the key points in our NHS organisations which we need to influence in order to enable our clinical teams to change the things they do?
So for me, and I think working with the other leads, the first bit is the collaboration with the clinicians around, you know, what is it that we're constantly doing? Do you think it's working? Looking at the outcomes, bringing in the data, bringing in the finance and the procurement. What contracts are we tied into and for how long? How are those contracts actually working? What is the finance position? It's got to be a multi-dimensional team that looks at this. And I think that's one of the first bits. But the clinician at the end of the day is the expert on this, and often are desperate to be doing things differently. And often it's the system that stops them from doing that. It's also, I find, really difficult to bring in new ways of working and to enable that to happen whilst keeping the everyday clinics going, what with time pressures and everything else, the waiting list, performance measures needing to go to Welsh Government. And as Tom said earlier, you know, sometimes doing this work means that the performance measures that we have targets on are at different junctures with each other. So, you know, we do need to have an understanding at regulatory and also audit and Welsh Government levels. I think it's also really important about how we fund these programmes. So often, even with value-based healthcare, we've got a bit of an in to try this thing, but the key bit, as both Chris and Navjot were saying, is getting the data, the evidence that says we've met the clinical need, we've met the goal, we need to change the targets, and how does that actually enable us to look at the 7 years worth of waiting lists, and then how do we look at the workforce moving forward? But as we know, the NHS can be a slow-moving beast. It is complex, it is very, very difficult. We can have annual targets, annual funding, as well as depreciating health of people who are on our waiting list that can throw all of our priorities out. So it is a really complex area of work, which is why we're all here to discuss it. But I do think there are a lot of opportunities. I think the opportunity with the digital and the data enabling and intelligently using that, not just to say, have your waiting times gone down? How many people are there? But more, how many people are back doing what they wanted to do in meeting their goals? I think as well, and I've got a couple of questions that have come through, so we'll put those through. So keep them coming in the chat for us because they are coming to us. Is that we want to avoid a confusion of value-based healthcare and person-centered value-based healthcare and all the different definitions that fly around. And in previous podcasts, we've discussed the maturity of value-based healthcare, and you know, we had a session on sustainability. One thing I think this enables us to do, as we do in value-based healthcare, whether you put the PC at the front or you don't, is very much that person-centered pillar. I think thinking about it from the micro, meso and macro level is really useful because it gets us thinking about that in front of you person human discussion. It gets us thinking about the service review and what do we need for the service and how does that data actually coming through when we consider those goals. And then at the macro level, especially in this journey phase, is how do we all work together to share that? We don't all need to be doing the same projects at additional cost, additional time. if we can continue to keep sharing what is working and what's coming through. And I think the other eye is as Tom was saying, things are changing so quickly in technology, in interventions, in pharmaceuticals, and working with industry and looking at procurement and different ways of contracting is definitely part of this as well.
Well, thanks, Dee. Sorry to put you on the spot.
No, that's fine.
So we have got some questions coming in the chat bar. And a few comments as well. So I think Ailsa sort of suggested perhaps the system, in inverted commas, needs to give greater autonomy to clinical teams to do different things and allow them to fail before they succeed. Amen. And I like Bill's comment. We need to understand how we're going to communicate differently and how the narrative needs to be changed. That sounds very like Muir Gray and Muir's views on language and culture and that sort of perspective as well.
I would also take that one much further, and I think we've got new strategic equality plans coming out. It very much, we really need to get back to really understanding our communities and our populations and accessibility needs. We have many languages that are spoken in Wales, as well as English, Welsh and British Sign Language. I wouldn't say we're the best ever at all of that information, and yet how do we expect our patients to be able to come in with families and carers, if they have them, to understand, and then to be able to, okay, I know what I want to ask, I can communicate, think I'm understanding more about my condition, and now I'm being asked to understand the interventions and what they'll mean for me as well. I think we've also got to look at the generations, because there are different generations. I don't personally agree with triage checking on waiting list where a patient will receive a letter and says, do you still need this? Because many patients won't want to put people out, might want to think, oh yeah, I do, without knowing. And I do think there's something more around the goals. So where are you now, and are you able to achieve what it was you wanted to achieve? So very much working in partnership. We have had a question come through from Sean Mayer. He did miss the first little bit of your talk, Tom, but he said that he feels that might you've been suggesting something of a hierarchy in value, i.e. we need to start by understanding and designing the care and services from what really matters or what really adds personal value, and then the other values follow on from that. Do you think that there is a hierarchy or sequence in which we need to do this, or can we start at anywhere at any level?
Yes, and now I don't want to hog the comments here, so I'm going to make this very, very quick, and then but you can follow up with me offline, of course. I have always struggled with this perspective of value from different perspectives, the different stakeholder groups, because in my view, there is only one value really, which is the person, the people we're treating, and then populations are aggregates of loads of individuals. And so I think that's what we have to focus on. What is it that a person wants that's seeking some form of care? What are those goals? What are those preferences? And how can we support them to achieve those and empower them to do so? I think this is very much also about letting people take responsibility for their priorities, and not us telling people and being paternalistic about what they are. And then we need to build that up so that what Dee was saying about understanding our populations, we can aggregate that data. There's no difficulty with doing that. And then we can take population level decisions about understanding, well, actually in Monmouthshire, what is it that people are wanting there? In central Newport, what is it that people are wanting there? And is it the same? Is it different? And I suspect there are differences. So we can start to understand and design services accordingly. And I would ask a question to say, and I think the answer to this is we have no idea, and it's something that I am very keen to try and help find out in general. What you were getting at, Dee, which is in our services, we have all this measurement, which I think, which is important often, but to what extent are we achieving the goals of the people that are meeting us? And I don't think we know that. And we should know that, in my view, and we should be able to do that without too much difficulty. I'll stop there. I hope that answers.
Tom, can I just come into Chris? So Chris, from the work that you've been doing, have you had any direct feedback in relation to how patients have felt about being asked what their goals are and being part of that conversation?
Mainly positive, if I'm honest. I mean, it's not new to us, particularly from a therapy background. I think we're very biopsychosocial with our approach naturally. So I don't think this is a completely new approach to our service, but I'd say recording it and the way that we're using the data and pulling it together with, you know, the PROM data and more traditional ways of looking at surgery or non-surgery from radiology, etc., is a new approach. So combining all of these different approaches into decision making, patients really like being asked the question. They really like giving you their goals, because I think it just places them central in the treatment and care that they get and makes them feel very involved. I think we find as clinicians that it really motivates patients, because they know that you know what they want and you're taking it seriously and you're putting it right up there as a priority. So I'd say generally the feedback around it is really positive, and it's a really good opening question for patients to understand. I think for us to get a good idea of their literacy as well, their understanding of their condition, which can be a big barrier to setting realistic goals. We often see with patients that come in with very unrealistic goals that they've got a very limited and low health literacy associated with that, and then you instantly know that you need to really work on that educative part to their understanding of their condition as a priority. So I think, you know, it's such a helpful way to start a conversation with patient, asking them what do they want to get as a goal and placing it right up there as a priority.
Oh, Chris, thanks so much. And just the massive value in having people like you join us in the session, because you are right there doing it one-to-one with patients and leading a team. It's just so valuable. And going back to the comments earlier about we shouldn't be doing these things in isolation. Well, this is exactly the reason why we have the Value-Based Health Cast, is because we can listen to people like you doing the things you're doing and then learn from that and spread and scale it. So thank you for that sort of first-hand account. I've got a question. So Michelle Symes had a question, which I'll probably take back to Chris and Navjot in a second, but I was just reading up through the chat, and it's really fascinating listening or reading people's comments and questions. And I think Robert Type from DHCW asked, are there any case studies of value-based contracts that have been constructed and agreed by the supplier where the supplier is paid based on patient outcome? Which I think is a really fantastic question, because it is linking in very closely to procurement and how we have conversations with suppliers about the care we're trying to deliver and trying to move. And I think what you're getting at there, Robert, is it's sort of an attempt to move away from a very old-fashioned model where you pay on a, you know, per dose basis, or a per procedure basis, or a per piece of equipment basis, and then you try and drive down costs as much as possible. So you've done a good day's work in procurement if you've secured 5,000 devices for the minimum cost possible. And that's, and I know, speaking to my procurement colleagues, they're really trying to move away from that, whereas you're engaging the supplier in a conversation about outcome, and they get reimbursed, remunerated, paid based on outcome achieved. And I think that, and certainly I know that Sally and Hamish in the Value and Health Centre have got examples of work underway around that. Robert, so if you did want to follow that up with them, I think probably Sally and Hamish are the right people to track down.
Yeah. We've also got a project at CTM where we're working in partnership, and this is open information, so I can share the case study information if you're interested, but with Roche Diagnostics and using Entipro BMP. So we're working also with DigiFarm, which is a Welsh-based IT company, because it's looking at how do you get that PROM and the outcome data, and I think importantly the experience, the goal data, to come back, and did that pharmaceutical or implant or whatever do what it said on the tin, and did it meet the goals of the patient? Is how do we mature and get that data to feed into our procurement systems? And it's almost a step of through the whole systems pathway of we've asked the goals, we've done what was asked, did we get the outcomes that we expected, that can then feed into Chris when he's going, okay, these are the intervention menu that we know, and these demographics, these people that they've chosen, these were their outcomes. So there is some work going on. It's still maturing, the procurement bit's still maturing. Navjot, did you want to come in on that one?
Thank you, and it's a really interesting question. I'm just going to aim to answer it quite briefly. So first of all, what's the challenges? What's the current challenges in having that as business as usual? So in order to have outcomes-based contracting or value-based contracting, you need the right data sets to be triangulated. What we're talking about here at the moment is a lot of process and structure data has been in place, which allows procurement to take those decisions around cost of the cost of the particular procurement and the resource implications of it. What they can't do at the moment is two things. One is the lack of outcome data that needs to be triangulated into that. And second, the lack of GS1 compliant data, which hasn't been not just in NHS Wales, but in many other health systems as well. I think as a nation, we're going to be getting very much better at having GS1 compliant data through Scan for Safety. What that's going to allow us is to track our implants, connect it to the patients, and then triangulate it to the outcome data. We're not very far away from it because our central procurement teams are on the case for it. And as health boards grow in their maturity in the adoption of the PROM standard operating model, we should be having the data standards so that PROMs are available in the appropriate data standards. And if the vision that Tom has and Chris is implementing around patient goals then comes into place, then we should be able to triangulate patient goals, patient reported outcome measures, GS1 compliant data, and actually track the patient's journey through the system to give procurement an informed view of the value-based contracting. So long story there, but probably that demonstrates our journey into where we are at the moment. And through what you mentioned, Dave, working with Hamish and Sally, and of course, our teams around, I think it's not a long till that vision becomes a reality on outcomes-based contracting.
Thanks, Naj. I'm loving the chat bar at the moment. There's just all these like comments pinging across, and I can see the connections being made, which is brilliant. Tom, sorry, you got your hand up there. Please do come in.
And just a thanks, just a quick comment on this with contracting, and I also think this is very important that we reimburse based on value, not just based on volume. But just reinforcing the point Navjot raised there, what we don't want, of course, is driving volume, but in another way, because what we potentially can do as we're defining standardized data sets and we capture those and we say these are the outcomes that matter, industry responds and says, well, we have products that can achieve X, Y, and Z outcomes, and then the sale focuses then on we're achieving these outcomes, we measure it, we're achieving those outcomes, they get paid and they get their greater reimbursement. So they respond to what we say. But of course, the risk with that is that we start achieving outcomes that don't actually matter. We believe they matter because we were defining it at populations, but for groups of people, they don't. And so I think we have to be cautious with this and make sure that the way we use medicine and the way we use technology is supporting the priorities of an individual, and that once we understand that, that's then reflected in the outcome data, and therefore the reimbursement can follow. But if we don't understand that first bit around that individual priority, the risk of perceived, I'm using complicated language now, but so excuse me for that, but the risk of perceived value is, but not actual value, if you see what I mean, is very high. Yeah, so I think we should be very cautious about that.
Thanks, Tom. It's a challenging concept, isn't it? Because as clinicians, many of us have been educated in a system where we're relying on randomized controlled trials, which measure, specific outcomes. And I think it's a very, just to take it to the full extent in terms of value-based recruitment, or sorry, value-based procurement, what we're really saying is that organizations who do research and drug trials or device trials need to be measuring out clinically relevant outcomes or patient relevant outcomes as a primary outcome measure for their studies sometimes, which is a challenge to extend to our partners. And we're now sort of in the last few minutes of the session, and I know Sally Lewis is waiting in the wings to come and join us for the last few minutes. But I did want to get to Michelle Syme's question, which was maybe for Navjot and Chris, but specifically, how can we influence Welsh Government's investment into the infrastructure to support the technological advancements when traditionally funds have been diverted from sort of non-direct patient thinking? So how can we influence Welsh Government to support the infrastructure and technological work that needs to be done? Navjot, I'm sure you have an opinion on this, will you?
So I think I'm gonna pass the ball to Sally to make a start on this one, because she's the expert in this, and then whatever she says, I'll come after that.
All right, Sally, there we are. Hospital pass.
Gee, thanks, Navjot. You can really go off a person. Yeah, it's a critical question, isn't it? And I think the truth is, we've made huge inroads in Wales into getting recognition that there needs to be investment and concerted effort in the infrastructure to do this. And we see that great collaboration around PROMS collection and PROMS software, which Navjot and Dee will have been directly involved with recently. And DHCW obviously have been a great partner with us in helping us develop the data standards. So we've had quite a lot of resource. The challenge now is to keep up that momentum and keep us on track in really difficult times within the NHS, really. So that would be the way I would answer that. I think we're on the road, but we've got a little way to go with some choppy waters ahead. Do you want to add to that, Nav, before I...
Thank you. That was amazing. So, building on what Sally said, I think my view is that, again, the Welsh Value and Health Centre have been instrumental in getting some of the resource allocations for these, for these value-driven, I won't call them projects, but approaches in health boards, as Chris and myself were describing. An inward investment from that really helped us scale up the prehab program. And one of the elements within that allocation is the digital element of it. So as much as what Sally described around the policy levers, I think it's really imperative on the organizations to build those things into this and start demonstrating some of the benefits. So it's a top-down and a bottom-up approach, both of them at the same time. So as we get more investments, we do need to recognize that we need to demonstrate the value of those investments in terms of resources, understanding patient goals, delivering patient goals, and all those areas as well, which I put on my slides around what are the benefits. Digital contributes to it. It's not everything, but it's a significant part of our journey, and that impact has to be demonstrated on and on and on, has to be a relentless focus on it. That's what my view on that one is as well. And Chris, do you want to talk about it? Because Chris has been the champion of doing this. Without Chris, we just wouldn't be able to do that.
I suppose from a clinical lead and on the ground perspective is trying, we've got responsibility, I think, as clinicians in an area to show good evidence about the change we're trying to implement and put in place for patients. We generally know what our patients want, and we generally know how to improve services, but maybe what we haven't been so good at doing in the past is evidence in that and showing where having improvements in services actually gives better value to a health board. So I think we can take some ownership and responsibility there of being good at collecting PROMS data and patient goals and showing how it's providing better services that are just as cost efficient to health boards. I think that's where our role sits within it all.
Thanks, Chris. And I suppose finally, as we draw to a close, I might just bring in Sally again. And Sally, in terms of where we are with asking our patients what's important to them, do you think we're making progress as a system?
Thanks, Dave. First of all, thanks everyone for another fantastic session. Really great to see the discussion going on. So there's 2 points really, because we've got 1 minute left. The first thing I think is a challenge to ourselves as clinicians, because very often I don't think we're as person-centered as we like to think we are, and there's lots of reasons why that is, and often that's time pressure, assumptions made, all of these things that we're susceptible to as human beings. So we need that self-awareness, don't we? And whilst we're on the subject of self-awareness, I put in the chat earlier, we're very ingrained in care processes that we were taught when we were trained. So we imagine a service in the image of the service we were taught. And that's reinforced by professional bodies like the Royal Colleges and so on. And it's not necessarily as particularly evidence-based as we imagine it to be. So challenging the way we deliver care, not the outcomes and not the interventions necessarily, but the way that we configure care processes can really help us understand how we can better utilise the resources that we already have. And obviously that's really important at the moment. Well, it's always important, but particularly now. And then the second point that I wanted to draw everyone's attention to is actually my old practice manager, Graham Hunter, who's put in the chat. Hi, Graham, great to see you. Graham is asking about how we embed some of those goals and choices into care navigation in general practice in primary care, which I think is a really interesting concept, because failure demand in the system, in other words, people turning up in the system at the wrong place where they're not going to get their needs met, is a big issue for us. And a lot of the things that we put in place to manage demand actually create an illusion of progress and actually don't help patients use up capacity, use up resources, and just we end up with a very frustrating system for patients that's very costly. So Graham's point, I think, was very interesting, and we need as much focus on failure demand at the moment, I think, as we redesign services, as we do on people's goals, preferences and outcomes. But thanks again, everyone. Great session.
Oh, thanks, Sally.
Yeah, so thanks everyone. We're right on time, right up to the wire. So I think that just demonstrates how interesting the topic is. The chat has been going nuts, so we haven't been able to get to everything. But as we said, you know, really take some time, have a read through, add any comments in there. We promise to get back to you on the questions. Thanks to all of our speakers. Thank you very much for joining us today. It's been another great session. Now look, just like I'm going on holiday tomorrow, there is no podcast in August. I know, don't cry. We will be back. We're back on the 29th of September, and there'll be a 3-part series on planned care with Sally Lewis and Will Oliver from the NHS Exec. So thank you all very much for joining us, and we look forward to seeing you all soon. Anything from you, David?
No, that's it. Thanks, Dee.
Thanks,
Thank you, everybody.
everyone.